So it's an honor to introduce the next presenter. He's Pascal Starinieri, a perfusionist from Hasselt. He's working in a team that has been dedicated towards minimum invasive cardiac surgery and combining them with MIECs. Unfortunately, we'll see a pre-recorded presentation, and I would ask for the presentation.
Good morning to you all. First of all, I would like to thank the organizing committee to give me the opportunity to talk about MIECC in combination with MICS, and also my apologies that I could not be present there in Thessaloniki. So MIECC and MICS, a challenging approach. To start, we also all know the classes of recommendations and also the level of evidence. So I was glad to see that MIECC was integrated or mentioned in the EACTS and EBCP guidelines of 2019. As mentioned, MIECC, let's say, should be considered to reduce blood loss and the need for transfusion, and also to increase the biocompatibility of ECC. So in our center, we use two types. We use a type 3 for all closed cases and endocabbage cases, and also partial stenotomy AVR together with a pulmonary artery vent, or we use the hybrid system with a pulmonary vein vent, and then meaning mitral cases and also thoracoscopic AVR settings where you have a pulmonary vein vent which is connected to a dual chamber reservoir at the side and two small tubes going down, so you have a small blood gas blood air contact here. We also have the EVO below here, because if you have venting blood, you need to give it back to a steady state. So we position then on certain percentages the EVO, but it will become more clear during this presentation. So safety mechanisms, which I was very keen on to use them starting, I think 10 years ago now, or 9 years ago, MIECC in our center. So we started with an SCP. So we had let's say an ECMO console, which has a bubble sensor. Bubble comes in, pump will stop. Then you need to open the clamp, which has all been done manually. Then we had an S5. So we integrated some safety mechanisms, some automatic safety mechanisms, which I will show you now. So we had, or if you have on the S5 or on a different other machine, you have ramp down functions, you have an auto regulation function, you have automatic clamps, and we have also bubble detection. To start with the ramp down function, it's triggered by pressure. So if there is an excessive negative pressure, the RPM goes down to a preset RPM, and afterwards you need to manually increase the RPM. Also be aware of the dynamic filling index. If you measure a -60 negative pressure at the venous line, it can go up to -200 at the inlet of the pump, damaging blood. So also be aware of that. So measuring, not only measuring the venous pressure, but also you need or a ramp down function, or as we do, another regulation function. It's the same. It's been triggered on a negative pressure. So excessive negative pressure, the pump will go down, you give some volume, and then it goes automatically up. It's been done automatically. In the ramp down function, you need to manually increase. In auto regulation function, you don't. So this is a small video. You see excessive negative pressure, and now type 3 in the back, you have one lid attached to the venous line, which you can fill the patient, and the red one you can empty the patient. In this particular case, we try to fill the patient. You see very negative pressure. You open the tubing clamp, a little bit of volume goes in, so your flow will rise, and also you have back again the steady state. Automatic clamp. We use automated clamps, arterial clamp, and also a venous occluder. So on a bubble sensor, it's been triggered your arterial clamp. So if there is an issue going a bubble, then your arterial clamp will close, so no air will go to the patient. And also, as mentioned before, at the hybrid system that we use below the reservoir, we have an EVO, you have a venous occluder for the venting blood. So venting blood comes inside the reservoir, it gets defoamed, and then you can give it back by the EVO, so you have a steady state. Bubble detection, we have a 1/4 drip chamber, you see here. 2-level sensor are not possible on the S5, so what we did, we kept the level sensor on the VBT, and we go a little bit lower for the 1/4. So aortic needle, aortic bubble comes in, aortic needle pops out, massive air. This bubble will detect the air and it will close the clamp. So you don't have any air inside your system. You put a tubing clamp here, no air, open the clamp, back in business, and you can de-air afterwards to the cell saver. 3/8 air purge control, also bubble comes inside your venous line. It will be detected by the air purge control and pump will start and automatically it will remove air. It's a small video for that. See, start of the air purge control, small bubble detected, pump will run, and air with a little bit of volume. It will drawn out and pushed to the back, which you can then reduce the volume. You see here, there is the bubble, and it's been evacuated automatically. Also, as mentioned, the safety mechanisms, we have a 3/8 below here because we switched from the level sensor on the VBT to the reservoir, and if there is a bubble here of more bubbles and your air purge control can't handle it, it goes here, this will trigger the clamp, so a bubble is not inside your centrifugal pump. This was a little bit, I showed you our two systems that we use, but in our particular case, and I think using minimal invasive extracorporeal circulation, type 3 or type 4, you're forced using a certain strategy. And in my opinion, it's a strategy that can work. So in our center, what's our strategy? We have cell salvage to de-air the pump, but also to have separate suction. So at the table, there's only one sucker that goes from the table to the cell saver. If there is a bleeding, in case of a bleeding, we can give a sump, so it can directly go to the pump then. But normally, in 99% of the cases, we do separate suction, so all the blood from the table goes to the cell saver. And normally, we use 225 bowls, and sometimes we have one bowl to give back. So separate suction, also coating. We try to do it tip to tip. It's not always possible due to back orders of cannula, so we try to go tip to tip coating. Also nerves and EEG, we use it in every case, every particular case, especially also in mitral cases when we do double venous cannulation for drainage. If you put a jugular cannula in, that you do not obstruct, let's say, or create venous pooling, which can also cause then also issues on the ICU for the patient. So that's why we use in every particular case, we use this. Also, we do a lot of groin cannulation, so that's also interesting to have these on board. As mentioned, also this is an article from Randolph Chitwood. As mentioned, we do a lot of groin cannulation, but be aware of the shape of the aorta. If it's quite thick and calcified, we go for another cannula of cannulation site. Assisted venous drainage, also very important, or kinetic or vacuum. Be aware of using vacuum with centrifugal pump. Then you can draw air out of your oxy. But also be aware of that if you have bad of assisted venous drainage, it's not a solution for improper cannula positioning. So that's why we use in every case TE also for a good cannula positioning. It's better for you as a perfuser, but also for the surgeon if it's well positioned. So do not use assisted venous drainage as a solution. If it's insufficient, it's a proper cannula positioning, but still insufficient, then you can use or vacuum or assisted venous drainage. And we use the kinetic, so we use an extra centrifugal pump in the venous line. Especially in this particular case, this is an endoscopic or thoracoscopic AVR. When the approach is from the right side, you see if you don't have a good drainage, the right atrium will block the surgeon's view. So that's quite important. We use a hybrid system for that one. As mentioned, below the reservoir, you have then the EVO. Venting blood goes inside the reservoir, goes through the EVO, which you can put on percentages to have that steady state and to have a really good, steady drainage. For the pump, we use centrifugal pump, which is the main driving force of our MIECC system. Also for venting the aortic needle, it's all been done by the centrifugal pump. As mentioned also before, for the safeties, link it to a ramp-down function, an excessive negative pressure, or another regulation function, but I also explained it this previous. Cardioplegia technique or myocardial protective strategies. We use our own cardioplegia and intracellular solution. We give one single shot, so it's easy for the surgeon as an endoscopic approach, one single shot, and it can go up to 2 hours, and we dilute the patient with 300 mils, so it's also easy to to put inside a MIECC system. Also, for the dilution part, we do a retrograde autologous priming. So we start by de-airing the system with crystalloid, and then afterwards we prime again with the patient's blood, as mentioned here. You see a tubing clamp on the post-oxygenator, the outlet, and then there is a line which goes to the cell saver. And also the entrocate autologous priming, in this particular case, what we do is we start going on bypass with a closed clamp. So all the crystalloid priming we push to the cell saver, and this is all dependent on the volume state of the patient. If everything is been pushed or the volume state or the pressure is low, we open the arterial clamp and then you go on bypass. Also important is training and education. What we did here in our center, we sat together with the surgeon, asking what he needs to do this minimal invasive approach, and then we built the system around that, and that's how we came to our final design, which I showed you at the beginning of this presentation. So it is important for all the stakeholders that they are aware what to do. It's a team approach. There is a bleeding or so on, it needs to be dealt with that, and also do not give as much volume as say if the anesthesiologist dilute the patient with 2 liters advance, you lose your beneficial effect. And as mentioned also, it is a MIECC strategy, so it's not only the system, you're forced using a certain strategy using the system, and I think the strategy that works. Also the safety mechanisms I showed you, if you have those safety mechanisms inside your system, then it can be as safe as a conventional when using the proper safety mechanisms. So the combination MICS and MIECC is possible. You have some ground rules, you have some safety mechanisms, but be aware that all the stakeholders look in the same direction and you know the critical parts of the surgery. So thank you for your attention, and I wish you a pleasant afternoon.
So this was a very interesting session. Are there any questions from the audience? If none, is there any question from the panel?
Some comments maybe.
I don't have too much experience with MICS, to be honest. We have one surgeon who does it at our institution, and we don't use MIECC with him. It was interesting, actually, what you said in your presentation, that you've had success with venous drainage unconventional, and then it was also successful in MIECC. And we struggle a little bit with our venous drainage in these mixed cases, so I'm not confident that trying MIECC would help very much.
So, Dr. Malvindi, do you have any questions?
Good morning. Hello. How are you? So I saw the session was fantastic. Really, compliments to all of you. So I'm very happy because you provide very, very clear messages. I want to do some small comments, if you agree. So the first one that, I do agree, completely agree, is that we have to change, probably from your words, from your presentation, I can say that we are in the process of changing the idea of the minimal invasive cardiac surgery. I mean, doing operations that are long, maybe demanding through a small cut is not minimal invasive, at least for us in Ancona. We apply the same principle that I saw from Professor Gunaydin presentation. So the other very important aspect, if you want to provide a reduced trauma to the patient, teamwork is essential. This was the second key words from your presentation. It is very important. And the integrated approach, such as the ERAS protocols that finally are coming up also in the cardiac surgery fields, are really promising. And probably this is the pathway that needs to be followed if you want to improve patient experience and the outcomes. I mean, the usual hard endpoints is mortality, cerebral stroke. These are the basis. I mean, patients expect to come back home. And so we need to work on the rest just to make smooth all the postoperative period. And finally, the last comment regards the older patient. Yes, we are treating older and frail patients. In our center, we are open to transcatheter procedure. I mean, we don't believe they are in competition. There are good solutions also, TAVI or transcatheter mitral for some selected patients. So there is no way. There are some of these patients definitely will benefit for a non-surgical option, but maybe better interventional option. The other point is on the younger side. I mean, we are treating also young patients now. There was some changes also in the guidelines. Some of these patients are thinking about mitral valve patients. Maybe they are mildly symptomatic. They are very active. So for this patient, operation, even cardiac surgery, is a terrible condition. I mean, it's probably they think the disease, the cardiac operation. So having such an integrated approach, I mean, you can do an operation, a surgeon can minimize the trauma, so providing small incision, the small anesthesia from the anesthetist, aggressive pain control, optimize extracorporeal circulation. When you can do MIECC, we don't do the MIECC for the mitral, for example, but we try to keep our operative times low. I mean, avoiding hemodilution. No? I told you yesterday, I know that blood cardioplegia maybe is the best, but we like to use now the nidocardioplegia. For us, it works, for example. These are all changes that you can achieve through really the teamwork. When I say teamwork, it means also from the research side. So we are very happy we got all our clinical perfusionists. They are really involved in all the aspects of the process in the treatment of the patient. They're just not delivering a technical action, no? But there is discussion. So every day, I'm happy we can learn also a lot from them and from the anesthetist. So I was very happy. I mean, it was a fantastic session, really. There's clear messages. This is a modern way to think about cardiac surgery.
So thank you very much for the comment. I think we should move on to the next session. Thank you.
Thank you.